I'd like to introduce you to Associate Professor Nick Wood. So Nick is a staff specialist, general paediatrician and associate professor and academic lead of higher education, higher degree research in the discipline of child and adolescent health at the University of Sydney. He holds an NHMRC Career Development Fellowship, and Nick leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital in Westmead. He is a senior investigator on the Primary Health Network Immunisation Support Program, and is interested in maternal and neonatal immunisation, as well as research into vaccine safety, including genetics and long-term outcomes of adverse events following immunisation. Welcome, Nick. I'll hand over to you.
Thanks very much, Margot. I'll just try and share the screen here, and hopefully we can get underway. So hello, everyone. So the job tonight is to sort of update you on COVID-19 vaccines and flu vaccines for this year. I'll just, why isn't it going down? Oh, there we go. So this is the topics. COVID-19 vaccine information, a bit about the flu vaccine, and then we'll finish off with those 3 extra topics. So as you've experienced, Australia has been extremely fortunate. We're not in any way like other countries with, multiple waves, and the last wave particularly affecting countries like Brazil and Italy again, and mainland Europe. The UK has been extraordinarily successful, and hopefully that their second wave will disappear because they've started to vaccinate lots of people. So it's been in our world, and you can't really escape it knowing about it. Australia, we've had 2 waves. This is the total number of cases going way back to sort of March of last year, and then in July and all. So the vaccines really are the way out of the pandemic, and there have been an enormous number of development put into the vaccines. This is just a snapshot showing that more than 180 candidates in preclinical development, a lot gone into human clinical trials, and there are now 4 that are in post-licensure surveillance. Australia has purchased and is vaccinating people with the Pfizer BioNTech vaccine, known as Comirnaty or Comirnaty, and then the Oxford Astrazeneca vaccine. We have also got pre-purchase agreements to use the Novavax vaccine. It's important to realise that the goals of the vaccine program are to reduce serious illness and death and some disease transmission, but the main thing is to reduce people from getting very sick with it and dying. The vaccine program strategy is a complex one. It's probably the most complex vaccine program we've ever rolled out, and that's because of the supply of the vaccine characteristics, which we'll talk a little bit about with the Comirnaty vaccine, and the local epidemiology. So in Australia, at least, there's not that sort of sense of the disease is everywhere in our community. It is encouraged, but not mandatory. So the vaccines that we've got are really the mRNA vaccine, the Pfizer one. Started vaccinating in February, so just over a month ago now. The problem with it is it does need to be stored in very significant minus, subantarctic freezing temperature. We've got about 10 million doses, and it's a 2-dose schedule. The other vaccine we've got is an adenoviral vector vaccine, a little bit more usual sort of cold chain storage, and it's given in 2 doses at 12 weeks apart, and that started just a couple of weeks ago. Now, you guys are closer to the action than I am with the GP rollout, and I'm sure there have been some issues with how it's gone, but so that's the plan for the Astra one. We will have some Novavax, which is a protein subunit vaccine. So we've got a sort of a nucleic acid one, a genetic one. We've got a viral vector one, and we've got a protein-based one. The Novavax one is not yet registered in Australia. How effective are these vaccines? There's some data coming out more and more now about the Oxford one, and particularly some real-world studies in the UK. And so overall, its effectiveness is probably around about the 70% mark. But against hospitalisation, one study in Scotland showed it was very effective. Not so effective against the South African variant, but reasonably good for the UK variant. The community one is pretty good efficacy, 85 to 95% effectiveness. And then there's a whole range of other ones here, which we won't go through, that are sort of being rolled out. In the Janssen vaccine has been licensed in the US, and will probably start to roll out there. So this is the community one. I showed you the hubs, the idea of it rolling out through hubs, and phase 1A, which is the population I'll show you in a second. The Astrazeneca one is this viral vector. Importantly, these vaccines don't contain any gelatin. So if someone says, I'm allergic to gelatin, that's not really an issue for it. This was how the government decided to roll out the vaccines, with phased approach, with phase 1A, B, 2A, etc. We're well into phase 1A and starting to phase 1B rollout right now. And you can see there, it's probably hard to read, but we'll leave these slides with you. The target groups for this particular planned rollout strategy. So this is sort of a summary of it. The vaccines are recommended for these top-line priority groups, such as the border force, quarantine workers. If we can get those guys and women, those men and women vaccinated, such that if they're the ones that are going to be coming in contact with the travellers as they come in, then therefore they're not going to get sick and transmit it into the community once they leave their workplace. Aged care and disability residents and staff, obviously healthcare workers, elderly adults, people with severe medical risk factors, Aboriginal and Torres Strait Islander, and other critical and high risk workers. There are lots of documents available now, more than there really have ever been on the government websites, and so I'll show you some at the very end. But ATAGI has a document on the clinical guidance of these vaccines. This really is a summary of the two vaccines on a single slide, including as you can see here, the approval, the presentation, the volume, etc. I've talked about the dosing regime of the two vaccines. They're both intramuscular, and here's all the excipients or the ingredients in them. Importantly, this one does have this polysorbate 80 in the Astrazeneca, and there is a PEG, this polyethylene glycol in the community vaccine. And why that's important is if you're known to have an allergic history or allergic reactions previously to either of those two components, then you need to avoid it. We've talked about this, the 21-day interval. The COVID Astrazeneca vaccine, ideally it's 12 weeks. In the vaccine trials, it was shown to be more effective when there was a longer interval between doses than when there was a shorter interval. However, it is being licensed with the ability to give it at a 4-week interval if necessary. We'll talk about this later on, but the preferred interval between the COVID vaccines and the flu vaccines is 14 days, okay? And again, if someone says to you, look, I'm traveling to the Northern Hemisphere and I've got to go and visit, we had a gentleman just a couple of weeks ago who was desperate to go and see his sick son, his unwell son in the US, and he just had his flu vaccine. He'd bought it off the private market and then got the call up to get the COVID vaccine. And it was within that interval of the 14 days. And so we had a bit of a risk-benefit discussion with him. The main reason there is this interval of 14 days is purely first principles. There's no studies out there to report on the safety and the immune responses when given together. They are coming. The UK is about to start a concomitant study where they're giving the flu vaccine with the COVID vaccines. If you start with one vaccine, we want you to finish with the other vaccine, okay? So that's just an important principle. Start with Astra, finish with Astra, okay? In terms of contraindications, this is the list of them here. There's a previous, if you had anaphylaxis to a previous dose, then you obviously have to be referred to an immunologist or an allergy specialist for consideration of the second dose. If you have an anaphylaxis to These components, like I mentioned, seek specialist advice. This is the sort of estimates of the anaphylaxis rates. This is from US data. We're not using Moderna, but it's around about 2.8 million. And the Astrazeneca one, we don't have a really good handle on the anaphylaxis rate for Astrazeneca. I think if you guys, when you do give the vaccines to the person, and the anaphylaxis have been reported, have happened in the first sort of 1 hour, like they often do, and most commonly in the first 15 minutes. What we're seeing is, and I'll show you a little bit later on, is a lot of what we would call stress responses. And so people are reporting shortly after the vaccine that they're getting a bit breathless, they're getting some tightness in their throat, a little bit of lip tingling and tingling of their fingers. And so some people have jumped in and given adrenaline, and then the person has possibly felt better because they were told they've got the medicine that was curing their allergic reaction. But if you can, when you see them and assess them, it's important to just try and think, what sort of true markers of anaphylaxis do they have, such as changes in blood pressure, changes in skin, truly swollen lips, wheeze on their chest, urticarial rash, etc. So we have had lots of reports of allergic reactions, some of which have been labelled anaphylaxis, but then when we go back and review them in a bit more detail, actually turn out to not probably be true anaphylaxis cases.
Nick, sorry to interrupt. Would you mind just moving your camera up a little, because we're just looking at your chin? Better.
Is that a bit better?
Yes, thanks, Nick.
Okay. So these are precautions for the COVID vaccines. You can see, I won't go through them in detail, and we'll talk a little bit later about the trouble with the clotting disorders. But defer vaccination if you're unwell. We like to give it intramuscularly. And if you do have an allergic reaction, then there's the 1-800 NCIRS number that you can ring, and we can sort of take you through what we would discuss with the patient and how we might manage it. But also we have a group of allergy specialists. There's actually 4 or 5 allergy specialists that we meet with on a weekly basis, and we can take cases to them for discussion about what to do with dose 2, etc. ASCIA has lots of really good information, and they're updating it quite regularly on the ASCIA, on the allergy.org.au website. So there are groups in the community who are recommended, however, weren't trialled in the vaccines. And that includes those with immunocompromise. So again, on first principles, both the community vaccine and the Astrazeneca ones are not live vaccines, not live attenuated vaccines, so they're not a safety concern for immunosuppressed people. And because of their higher risk of disease, of nasty COVID, then they should get the vaccine. But having the immunosuppression possibly means that their efficacy is reduced, and therefore they need to make sure they have other protective measures. There is not much safety data on this particular group, as I mentioned, because they were excluded from clinical trials. And so I think you can advise them that, we believe it's safe based on first principles, and the efficacy data is not yet available, but it will be coming through. And like I mentioned, go back one up. There is actually some ATAGI advice available publicly on these particular group of people as well. For pregnant women, the vaccine is not routinely recommended, but ATAGI likes to use these words, not routinely recommended, but not contraindicated. Again, there's no clinical trial data available because people who are pregnant weren't enrolled in the trial, although there is some data coming out of the US from a safety surveillance system where they have pregnant women in the order of tens of thousands have been vaccinated, and there certainly haven't been any acute nasty side effects or reactions to it. So some pregnant women may choose to be vaccinated. Look, possibly unlikely in Australia because of our burden of disease, but they might do. And those are in those particular groups, pregnant women who are high risk of exposure, who have underlying medical problems. It is considered safe for those women that are breastfeeding in their babies. And as I mentioned, although there weren't any pregnant women in the initial trial, they are now starting to trial the vaccine. On this health.gov.au, there is a decision guide for women who are pregnant, and it's a useful resource for them to go and have a look at as well. Okay, so in terms of the frail elderly, again, the vaccine is recommended for this group. They are increased risk of severe illness and death. It gets a little bit tricky in some sense because of those people who are in nursing homes who are at the end of life care may wish to not get the vaccine. There are some side effects which I'll show you from it, but I think that's an individual discussion with the clinician and the family. There have been some reports internationally of some deaths in aged care facilities after the vaccine. Now, as you know, deaths happen every day in aged care facilities, and so by chance they will happen after within a few days of a COVID vaccine in this environment. Again, health.gov.au has a decision guide for use of the vaccine in those facilities. In terms of flu and the COVID vaccines, we don't recommend co-administration. I talked about the idea of having a 14-day interval, and it's probably, there's no real requirement of having flu first and then COVID second. You can do it either way around. It's just usually due to operational constraints. So if someone has a booking for the COVID, take that one first and then go and get the flu afterwards. If inadvertently you discover that, oops, they've had the COVID vaccine within that 14-day interval, then we don't say revaccinate, okay? The usual side effects for both vaccines are in the first 48 to 72 hours usually. And so you could possibly caution the person that if it is very close administration, they might experience the side effects of both vaccines, but we certainly don't recommend revaccination. And once again, ATAGI has a statement on this. In terms of other vaccines, okay, co-administration with any other vaccine, like the Zoster vaccine, pneumococcal vaccine, is not recommended, and it's a usual rule of 14 days between the two. Same sort of story as a flu vaccine. If it has been given on the same day or within that day by accident, we don't need to repeat it. And at the moment, the prophylactic use of paracetamol or Nurofen is not recommended in the use of these vaccines, although that might change. Antipyretics and analgesics can be taken after vaccination for these side effects. Okay, so in terms of what we know about the safety so far, we've been doing what's known as the SMS Active Safety Surveillance System called AusVac Safety. We've been doing that for many years and looking at, meningococcal vaccine, pregnancy vaccines. And so we've started to do this with the COVID vaccines, rolling it out through the hubs, initially with the VaxTracker system, and in Western Australia with SmartVax, and it will now start to roll out to provide surveillance in the GP environment as the GPs start to give more vaccines. Essentially, it's the same system. The person who has the vaccine gets sent an SMS text and asking them for some reaction report. And if that person reports this to had a medical attendance, that then gets flagged with the clinic, and the clinic is designed to follow up with that person and notify the public health unit in New South Wales. We have been delivering the survey. This is some sort of screenshots of the survey now for nearly a month. And here are some of the sorts of questions that we're asking people. Have you had any, what sort of underlying medical problems do you have? Did you have any reactions? What did you have? Fever, chills, rigors, etc. And so far, as of the 21st of March, there will be a new public report going up tomorrow with nearly, I think it's about 80,000 participants now have responded to the surveys. Pretty good response rate of nearly 70%. And you can see there that about 45 participants are reporting any adverse event, and about 1% are saying they needed to go and visit the GP or doctor after it. We send the survey on day 3, and then we send another survey on day 8 after each dose. So all up, the people get 2 surveys after each dose, and then they get a late survey on day 42. And that's designed to look for sort of, more longer term side effects. We've been doing it with Community and Astrazeneca, and this complements the TGA activities. Tasmania and Victoria have just started to commence participation in the last week. So this is what we know from the community dose 1. We've got more data on that because it's been used since February 22. And you can see here that injection site pains about 30%. Fatigue and headache and muscle aches are sort of in the order of 10 to 18%. And then those other ones are not so common. So pain's the dominant one. And certainly when I got my dose 1 of Pfizer, that's what I experienced was injection site pain. I didn't get much of the others. AstraZeneca, a slightly different story. AstraZeneca has a more significant side effect profile. You can see there that there is fatigue, headache, joint pain, much more commonly. So about half of the people are reporting these particular things. Chills and fever are a little bit less common, but about a third as well. Around about 2.4% of people are reporting any medical attendance. So that's the side effect profile there of that particular one. In terms of, basically what's happening is that people are reporting a flu-like illness. And so that's certainly what it looks like after Astra dose 1. And the data that will be released tomorrow shows quite a similar profile with Pfizer dose 2. So lots of headache, lots of flu-like illness with muscle aches and pains, some chills and some rigors, And so the Global Advisory Committee on Vaccine Safety, which is GACS, has put out this summary statement saying that you can expect to see this sort of thing. So my advice is that when you see your patients, forewarn them that they might experience this sort of issues. And it's likely to happen in the first 24 hours. They can take some Panadol or Nurofen if they're allowed to sort of dampen down their symptoms. But it's usually gone by about day 2 or so. And certainly when we've surveyed people at day 8, over 95% have said they're back to normal. So it is a reactogenic vaccine, and it does give a bit more of a kick, so to speak, than the flu vaccine does. The vaccine, because it does cause these symptoms in the past, we've all been, attuned to the fact that if you do get these symptoms, go and get a COVID test. Well, the vaccine can do this, and so we're not saying that you rush out if you've got fever, headache, and fatigue to get a COVID test. But if you do get things like runny nose or sore throat, then you should go and get tested because they're not likely to be caused by the vaccine, and follow the local public health advice. We don't recommend any testing for anti-spike antibodies, doing COVID serology before the vaccine to demonstrate immunity or even after the vaccine. And certainly if someone says, yes, I had COVID disease, then they can probably have a little bit of a grace period in which they get the vaccine and can probably get it more around about the 6 months after the vaccine. No urgency to get that. So these vaccines now have been given to more than 300 million people around the world. Okay, so we would have picked up, events admittedly, the doses are different in each country. So the United States is predominantly Pfizer and Moderna, whereas the UK is predominantly Astrazeneca. So there have been a lot of experience, and Israel is certainly a country that has given a lot of vaccines. I talked a little bit about the frail elderly. Again, the WHO has put out a statement talking about that. And the TGA has also put out a statement which has concluded that there is no specific risk of vaccination with causing severe reactions or deaths in the frail elderly. As I mentioned before, these things do unfortunately happen every day in aged care facilities around the country. Now, this has been in the news a lot, and it's this link between clots and particularly type of clot. The clot that is just has been potentially linked to the Astrazeneca vaccine is a clot that causes thrombosis from low platelets in the cavernous venous sinus thrombosis. That's what's known as the CVST. And so some researchers in Germany have come up with a name for it, and they're calling it VIPIT, and that stands for vaccine, I think it's vaccine-induced prothrombotic immune thrombocytopenia, or prothrombotic immune thrombocytopenia. And so the cases that have been reported are not many of them, but they have been reported occurring somewhere between 4 to 14 days after the vaccines. As we said here in Australia, we do get thrombotic events on an annual basis of around about 17,000 cases every year in Australia. So again, these DVTs happen spontaneously. But the particular one that people are worried about is this venous sinus thrombosis in the head in association with low platelet count. ATAGI is meeting actually today to put out a revised statement about these thrombotic events, and they'll probably come out in the next few days, I expect. We've not monitored or found, we've monitored, but we've not found any cases of these particular events in OSVAC safety. So it does appear that it's a very rare event, and what it means for the AstraZeneca vaccine, what it means is that ATAGI has said that if you have a past history of cavernous venous sinus thrombosis or a past history of a heparin-induced immune thrombocytopenia, which is known as HITS, then you should defer vaccination with the AstraZeneca vaccine for now. Okay. Anaphylaxis, we talked a little bit about that before, and I've shown you these figures before. AstraZeneca is probably about 1 per million, but we don't have any really good handle on that. And I think the important thing for you guys is to make sure that you, if you do see an allergic case, try and get a good history as to see, is it really allergic or is it a triggered immunisation triggered stress response. Cold chain management for the AstraZeneca vaccine is pretty good. You can see it's mainly 2 to 8 degrees. Comes in multi-dose vials. There's some more information we'll leave with you about how they should be stored to protect the vaccine from light. And there's some more rules about when it has been punctured, how long it can be stable for, and when it has to be used by. The vial can be refrigerated after first opening, but the total storage time must not exceed 48 hours. Okay. As you know, if you want to give the COVID vaccines, you have to have completed the training. The training is online through the Australian College of Nursing, and you'll see there some rules about who's allowed to enrol in it. And there are core modules. I think as shown there, the 2 modules about the 2 vaccines, Pfizer and AstraZeneca, are available. And the core modules are ones there about, the handling and the storage and the multi-dose vial training, which is a new thing for many GPs and GP nurses working in GPs. There's a web link to it there. In terms of legislation for providers, the rule, the APRA says that those who are trained, educated and competent can administer the COVID vaccines. There's more rules about there, about who can do it. Importantly, authorised nurse immunisers, and they're approved under relevant to authorise and administer the vaccines. And enrolled nurses and RNs can give it as part of their normal duties when they have an order from a prescriber. And ultimately, pharmacists will probably also be able to give it. But the key thing is that the vaccine providers must complete their mandatory training. Okay. There's a whole lot of information available for you on the APRA website. So I'd go and have a look at that if you get time. So in terms of mandatory reporting to AIR, it's now mandatory to report all COVID vaccines, and it is also mandatory to report all flu vaccines. And from July of this year, it's mandatory to report all NIP vaccines. And this list is for anyone, including GPs, pharmacy, hospitals, aged care facilities, and corporate providers. Okay. Some of the questions that we get asked is the vaccine mandatory? No, it's not mandatory. And you can choose whether to have the vaccine or not. And it doesn't affect your family tax benefits or childcare assistance. It might well be that in the future that the vaccine against COVID could become a requirement for travel to certain destinations, but we're not sure about that yet. You can't choose which one you get, okay? The supply is limited. We have less Pfizer than we do Astrazeneca. And so you really have to, unfortunately, you won't be able to choose which one you get if you have an interest in choosing the vaccine. How long will immunity last? So we don't really know how long it will last. The trials sort of finished up in December, but the people who are on that will be continued to followed out to have their antibodies measured for at least 12 months. And so we'll get some more information about the duration of protection. We talked about this. If you've had a COVID disease in the past, you should still get the vaccine. The vaccine clinical trials have included people that were seropositive at the outset before they even got the vaccine, and the vaccine was safe and produced an immune response. If you have a previously diagnosed with COVID-19, talk to your healthcare provider, and you just work out whether or not what timing you should get. There's probably no harm in waiting about 6 months until you've had it, as I mentioned earlier. Okay, and there's information on the website. In terms of the future, we're getting more and more safety data from the vaccines as they roll out into the community. In general, the mRNA and the viral vector vaccines like the Oxford Astrazeneca are more reactogenic than the Novavax ones and more so than the inactivated vaccines. We've not seen concerning serious adverse events in Australia. We've had a few reports of severe allergic reactions, but not had any venous thrombotic events reported to the TGA or to the AUSVAC safety. There are still some unknowns, however, therefore that's why the surveillance is critical. In the future, we'll get a better handle of how the vaccine works as the trials start to be done in pregnant women and children, and they start to enrol those with immune suppression. It could well be that the immune suppressed person is better off having what's known as a mixed schedule, perhaps getting a Pfizer dose 1 and then an AstraZeneca as a second dose, that sort of thing. So that's being looked at by the UK at the moment as well. There's lots of resources out there. I won't go into detail, but there's lots and lots of it. It's a bit overwhelming in some ways. And so I'll just leave you with that. Lots of links there as well. So maybe I'm just thinking before we go on to flu, Brooke, whether we should just have any questions specifically about the COVID story.
Yes, sure. We do have some that have come through. So, Nick, if you could talk to the use of the Astrazeneca after the Pfizer dose. So if you've got a patient who received a Pfizer dose maybe in the UK and is now seeking a second dose here, what are their options? Can they use the Astrazeneca one? So if you could maybe talk to the use of Astrazeneca after the Pfizer dose or vice versa and advise where they should go.
Yeah, that's a good one. And I know New South Wales Health is thinking on that exact question. So I think for the short term, if you could probably give the name through to the public health unit, then that name could go on to the Ministry of Health, because I think they are trying to facilitate for those people that got an overseas dose to get the same dose for them, if that makes sense. So we probably prefer they did not have a mixed schedule. They try and complete the schedule with that same dose. And I know the ministry is thinking about, or that we've actually sent names through to them of people that in that exact predicament. And I think they're trying to arrange for them to get into a hub to get the Pfizer, because you can only get a vaccine, the Pfizer vaccine in the hub.
Okay. We'll include some details about that in our question and answer one as well. Thanks, Nick. The next question was the COVID vaccine and anticoagulants. What precautions do you need to advise patients who are on NOAC and taking COVID vaccines? And NOAC is obviously a non-vitamin K antagonist and anticoagulant.
So at the moment, the thinking is that if they've not had a past history of this cavernous venous sinus thrombosis or the heparin-induced thrombocytopenia, they're allowed to have the COVID vaccines and the Astra one, because they're at risk of bleeding, etc., bruising, and it's just like any other vaccine with the putting pressure on the arm, etc., to stop any bruising. But there's no contraindication just because you're on anticoagulation at the moment.
Okay. And again, we'll include some details about where you can find information in the ATAGI statement as well as the handbook in our follow-up for that. Yeah. Next one, COVID vaccine for providers. Is it mandatory for providers to take the vaccine? So I'm assuming
no, at the moment it's not. At the moment, from my understanding, it's not mandatory for anyone. And even those that are working in the frontline emergency departments, it's not mandatory for them either. It's up to you to decide whether you want to take it.
Okay. COVID and
bearing in mind, as I said, that that's okay. I was just say the side effect profile is such that the Astra dose 1 is more reactogenic than the Pfizer 1, and then Pfizer 2 is sort of similar or a little bit slightly less reactogenic to Astra 1. And Astra 2 from the trials is less reactogenic than Astra 1, if that makes sense. And in general, the older you are, the less likely you are to have a sort of, a systemic reaction, including the fever and the chills. So it's much more common in the under 50s to get this sort of systemic type side effects.
Okay, and COVID and CKD. I have patients with chronic kidney disease. Is the COVID vaccine safe in these patients? Yes.
It's safe for them. As I said, there haven't been many people with CKD or transplants or those on dialysis enrolled in the trials because they were all excluded. But again, on first principles, because it's not live vaccines, it will be safe. How effective it is, I can't quite answer you.
Okay. And COVID and Guillain-Barré syndrome. Could you comment on the use of the COVID vaccine in a patient with a past history of Guillain-Barré syndrome?
Yep. At the moment, there's no contraindication to those that have had Guillain-Barré in the past and the COVID vaccines. There is a little bit of rules, as you know, about the flu vaccine and past Guillain-Barré that might have been linked to the flu, but for COVID, there's no such rule. There was a couple of cases of Guillain-Barré type events, transverse myelitis in the trials, but it wasn't felt that there was any safety signal there, and it's not been, as far as I'm aware, reported or picked up in any of the the pharmacovigilance work that's happening around the world. As I mentioned, there's more than 300 million doses that have been given around the world. So long answer, but if you've got a past history of Guillain-Barré, the moment there's no contraindication having the COVID vaccine.
Okay, thank you. And just touching back on the anticoagulants again, just an extension of that question. If a patient has a bleeding disorder, is taking warfarin and on INR monitoring, how recent of an INR results do they need to be provided for the patient? And what is the range that is acceptable in order to have the AstraZeneca vaccine? I believe we had this question today.
Yeah, I mean, whether you guys, I don't know the number, I'm afraid. I could look that one up and get back to you. Did you get in advice, Brooke, from another source?
I believe one of our GPs did. We directed them to NCIRS.
Yeah, okay. I think that might have been why it came through to us. I think we would like the INR to have been within the last week, probably even within the last 3 days. I'll have to get back to you on the level on that. So maybe that's an action item for me.
Okay, done. And we might just do one more and let you move on. Are there any medications that need to be monitored before the COVID vaccine?
No, when you say monitored,
don't have an extension on that.
No, it's more just the past history of allergic reactions to the ingredients or the previous doses, and these history of these, particularly the venous sinus thrombosis and the heparin-induced thrombocytopenia. They're the main contraindications at the moment.
Okay. Would you like one more?
Yep, sure.
COVID and the cortisone injection. If you have a patient that has had a cortisone-guided injection within 14 days, may they have the COVID immunization?
Yes, that's fine. Yep.
Easy one to finish on.
Yes. Yep.
There'll be some more.
We'll just gallop through flu in the last sort of 10 minutes or so. Flu really was, these are you can see 2009, 17, 19. 2020 was an extraordinarily boring flu year. There was no flu, pretty much. In terms of vaccine coverage, we do better in the elder group than the youngsters. We do a little bit better in the comorbidity group than those without no comorbidity. In terms of the Indigenous population, you can see here that it's not bad in the over 65s and not too bad in the over 50s, but we don't do so well in that sort of middle age group there, and the 5 to 50-year-old age group. We're doing okay in the under 5 years, but we could do better. Okay. FluCan is a national surveillance system that tries to report on the effectiveness, and this is the overall effectiveness in 2019. It wasn't brilliantly effective. It varies from the strain and the target groups, but not brilliantly in 2019. In 2020, we didn't really have enough cases in FluCan. In fact, there were only 14 cases in the entire group of FluCan, so we really can't make much sense of the effectiveness of the flu vaccine. So we can say that pretty much since March of 2020, there hasn't been any flu really. Vaccine coverage is not too bad in some groups, but we could do better. In the flu vaccine strains for this 2021 are shown here. There is the egg-based vaccine, and you can see the strains there. And there is, for the first time, a cell-based flu vaccine. There's lots of information that will be available or coming out on the ATAGI statements, and I don't think it is out yet on the health.gov.au. So they're the 4 strains. The key points are that it is recommended for all those over the age of 6 months. All the vaccines for this year are the quadrivalent ones. For the over 65s, the adjuvanted one, known as Fluad Quad, is preferentially recommended. The dose for all ages is 0.5 ml, no half doses for children. And as I mentioned, we've done this several times, not on the same day, and try and spread it by 14 days if you can. There is a new cell-based vaccine which is newly registered. It's not NIP funded. To be honest, I don't have a lot of information in the slides about this particular vaccine, the cell-based one. So we can probably send you some more information afterwards about that one, but it's not on the NIP vaccine. And like we said before, the vaccines are now mandatory reported. Recommendations and NIP eligibility. Oops. These are the groups. It's funded for those aged 6 months less than 5, Aboriginal and Torres Strait Islander, pregnant women over 65s, and those over 6 months with increased medical risk factors. This is the sort of, brands by age and whether are registered or available for. This is available, you can see there on the health.gov.au resource page. The main thing being that the over 65s Fluad Quad is probably the best one. Okay, there'll be lots and lots of information coming out from New South Wales Health and other state and health departments. Eligibility for the free flu vaccines, you can see there the 2 vaccine brands that are funded for that age group. If it's the first time you get it, like we've done in the past years, you need to get 2 doses. In the 5 years to 64, there's the brands, and then the over 65s, it's the Fluad Quad. So there's some rules there for you. This is the usual story we get every year. When should I give it? And it's even harder to say that now because we really did not have any flu last year. And with the intermittent sort of short, sharp shutdowns of community or cities, we may not have much flu again this year either. But what we do know is that we obviously want to vaccinate before the flu arrives. Flu probably makes its way around the world through travel and transport, and when there's not that much travel and transport, there's not much flu. So we probably won't have much of a year, but I don't really know the answer for sure. It could be around, just don't know. And so we obviously want to give it before, and we want to we think the protection lasts ideally in the first 3 to 4 months. So when it's available, and ideally from April to May. And that's a tricky thing because at the same time, we're trying to roll out the COVID vaccine as well. We've talked about the second dose being recommended for those people aged 6 months to 9 years getting for the first time, and any people who are have had a previous stem cell or solid organ transplant getting it for the first time. ATAGI has this sort of statement which says receipt of 2 separate doses in the same season is not contraindicated, and this might benefit some individuals such as those that are on travel or pregnancy, but it's certainly not contraindicated, but there's no real data on the effectiveness of it. I won't go in much detail of this. I think this is just repeats of the previous ones. I suppose one way to approach it was those who are in the early phase, 1A, 1B, should get their COVID vaccine now and then get the flu vaccine later. Those that are in the phase 2A, 2B could get the flu vaccine now and then the COVID vaccine a bit later on. Lots of information available on the health.gov.au and NCIRS. Just to remind everyone that egg allergy is not a contraindication, particularly even egg anaphylaxis. If you've got a latex allergy, yes, you can still use the flu vaccine. And just to finish off with, I'll leave you with these. There's lots of information that is available, and so you can have a look at all that on the New South Wales Health and the ATAGI statement. I did get that wrong. It is actually available there. And just to finish off with, some people are hesitant and probably will be hesitant about the COVID vaccines as well. And so to direct you to the Sky website, which is this one here for parents, talking about immunisation.org.au. There's lots of information there about those that are hesitant or want more information. For providers, there's a nice e-learning module on NPS website, which you can have a look at. And again, there's a provider website which guides you through how to discuss with the vaccine hesitant patient of the pros and cons of vaccination. So that was pretty much it, Brooke, from me. We're just under the hour, so if any more questions, I'm happy to have a chat.
Yes. So at the moment, there's only one for flu, but there are a few COVID ones waiting in line. So on the flu, in regards to Medicare eligibility, can a patient or a pregnant woman who does not have a Medicare receive the flu vaccine under the NIP?
That might be one that you guys need to answer. Should they get the vaccine? Yes. If they're, I think probably, I could be wrong on this, but my guess is if you need to have a Medicare card to be eligible for the NIP vaccine, I would think, but maybe someone else wants to answer that one.
Ask the public health unit, I think would be yeah, it's one of those, probably wouldn't put it in writing, but most GPs would make their own judgment call on that.
Yeah, I think there's that's right. There's, dare I say the word leakage?
Yes, for a good cause. I'll just jump back to some COVID ones while we're waiting for those influenza ones to filter through. COVID vaccine and cancer. Can patients who are undergoing cancer treatments, i.e. they're having the prostate injection, have the COVID vaccine?
Yes. So even though they might be ultimately cancer patients having some immunosuppression, again, we think they're safe. We just don't have any data on the effectiveness. In Ausvac safety, we're actually capturing some people's medical history, so we'll be able to report a little bit on their underlying rate of reactions according to your medical illness, such as whether or not you had, cancer or diabetes, etc. But we just don't have any of that data right now. But in terms of safety, it's fine that the immunosuppressed people can have the vaccines, but how effective it is, I just can't answer you.
Okay. COVID vaccine protection. Does the vaccine protect receivers from disease, infection, and spread?
So it definitely protects you from nasty disease, so death and hospitalisation. It probably protects you from moderate disease, but in terms of spread, the jury's a little bit out on that, and more data is coming in. The Pfizer one probably had some protection against transmission, but that's being studied at the moment, and that's important for herd immunity, obviously, the ability to protect against transmission. It was looked at in the trials, but not in all the trials. They initially were just focused on the antibody responses and then the efficacy against hospitalisation. To do against transmission, you need to do sort of regular swabs of the people in the trial environment and see whether or not they get swab positive but no symptoms. And the Pfizer vaccine showed a little bit of that effect.
Okay. Question on the COVID vaccine and methotrexate. Is it true you can't have methotrexate 1 week before and 1 week after COVID vaccine?
I don't know the answer to that one. I'm not sure where that came from. I might take that one on notice as well and get back to you on that one.
Okay.
I haven't seen any documentation on that particular fact, but
the COVID consent form. Why are mast cell disorders listed on the consent form?
I think there's a concern that the vaccine might cause you to have, the degranulation of the mast cells and have an allergic reaction. So that was one of the, we've got it up here. I think it's in the precautions. I'll just see if I can go back to it. Sorry, I'll just keep. So I think it was listed as one of the precautions. I don't think we've actually had any cases reported on it. I'm just trying to find it. Sorry, it's taking a bit of time to get back there. Oh, should have just gone back the other way. Anyway, oh, there it is. So yes, so the known systemic mast cell activation disorder. So these people, you know, any stimulant can cause the mast cells to activate and therefore have an allergic reaction. Not any stimulant, but some stimulants. And so there was a concern perhaps that the vaccines might do that. And so as shown there, and as by the ASCIA guidelines, people that do have this particular problem should be observed for at least 30 minutes following administration. There's also people that we're hearing about that have a history of chronic spontaneous urticaria. And so we're just working our way through the allergy clinicians with those ones about what to do with them. So I think it's fair to say that some of these severe allergic disorders, if you're unsure, just phone the Ministry of Health, Public Health Unit or the NCIRS number. And as I mentioned, we've got access to 4 or 5 allergy specialists and we meet with them weekly to discuss these cases.
Okay. Another eligibility question for you. One of my patients has Wilson's disease. Is she eligible for the COVID-19 vaccine?
I think so. Yep. Can't answer which phase she would be in, but no, I think she's definitely probably is phase 1B, phase 2A, probably.
Pop it in the eligibility checker, maybe.
Yep.
Is that specific? Okay, my patient.
I'd be interested to see if the eligibility checker can answer that one. But...
Yeah, if it's that specific. We'll see. We'll provide some links for specifics on eligibility in our follow-up as well. COVID and APHIS. So my patient had a blood test after his second Pfizer dose, so 4 days after, and his platelets are 134. I assumed it was due to the vaccine. I was going to do a repeat full blood count. Is this event to be reported or not? He is asymptomatic.
Look, I probably would report it. I was interested to understand why the blood test was taken, whether they had clinical evidence of, you know, bleeding or anything. So my advice would be to definitely report it. And then, yes, it is worth repeating the full blood count again later on to make sure the platelets come back up.
Okay. COVID vaccine hesitancy question. I've been asked to tell AIR that a patient is not suitable for flu vaccine due to her Graves' disease and fear of autoimmune disease. She works in childcare. Is there any need to do this? And is vaccine anxiety a lousy reason not to proceed?
Well, vaccine anxiety is real for the person. I missed the reason why the person didn't. She was afraid she had Graves' disease.
She has Graves' disease and she has a fear of autoimmune disease.
So it probably gets down to unfortunately, it wouldn't be eligible as a medical exemption for the flu vaccine. And it gets down to how mandatory it is in that workplace for this flu vaccine to be given. Certainly in the healthcare workers, it is mandatory, but it wouldn't be unfortunately would not be a reason. Anxiety would not be a reason to have a medical exemption for the flu vaccine.
Okay. COVID and infusions. A person receiving a weekly immunoglobulin subcutaneous infusion, can they have the COVID vaccine?
Yeah, that's a good question. I know that there is some ATAGI advice coming out on that one, so I might wait. I think if it's a weekly infusion, it's going to be hard to time it. I think if you had the chance to time it for the monthly infusion or so, you'd try and give it maybe midway through the month. But for a weekly one, it's a bit tricky. So I will. That's a good, important question. And again, I'll take it back to our target team.
Okay. I have a flu one. Yay, poor flu wasn't getting a look in for a while. Does a patient less than 65 years old with bone marrow transplant for aplastic anemia need to have flu quad vaccine or the usual vaccine recommended for people less than 65 years old?
Look, they're probably better off having the adjuvanted one, and the rules probably would state, because of their age, they just get the routine quadrivalent flu vaccine.
Okay. That's all the questions we have at the moment. Anything else, unless if we have some extra time at the end. Nick, are you able to stay on, or do you have other duties to attend to?
No, I can stay around, that's fine.
Okay. If there's more questions that pop up afterwards, we will ask them to you. So.
Great, okay, I'll stop sharing, thank you.
Thank you so much, Nick. That was really interesting, and I'm sure there will be some more questions come up because it is such a complex area that we're trying to get our heads around. So thank you so much for that. We're next hearing from two people from the Central and Eastern Sydney PHN. I'm sure most of you already know Brendan Goodger, who is, I'm sure, is the General Manager of Primary Care Improvement. I think, is that your right title, Brendan?
Yep, that's the one.
Fantastic. Over to you, Brendan.
Thank you for that. Do you just want to bring the next slide up, guys? Thank you for that. So look, I'm going to give a bit of a cameo appearance tonight in terms of giving you a bit of an update in terms of, if you like, some of the mechanics in terms of the what's happening on the ground in terms of the COVID-19 vaccine rollout. So in terms of RACFs that were part of 1A, at the moment we have about 53, we've got about 165 RACFs, aged care facilities in our region. And of those, so far, about 53 have received one vaccination, or the residents have received one vaccination. We have 6 who have completed both vaccinations, which is good. And really what we're hoping is for this to be accelerated over the next month. It's been that the rollout in the first couple of weeks has been a bit slow, as we've been sorting out the various sort of issues around the delivery of the vaccine, making sure that there's enough staff from the vaccinators as well. So there have been some teething type issues. At the moment, there are 3 vaccinators in our region. They are Healthcare Australia, International SOS, and Sonic Healthcare. And those 3 providers are working to deliver the vaccines to the aged care facilities. Again, we're hoping that the momentum starts to pick up. And over the last week it has. We've had about, I think, 25 or so vaccinated in the last week, and I think that will continue and hopefully gather a bit more momentum. In terms of how GPs can be involved in the rollout, well, I think it's about interacting with your RACF, making sure that you advise the RACF of any patients that you may have any particular concerns about, and also keeping an eye on any adverse events after the vaccinators leave the facility. These events may occur for some time, so about being aware of that and about what are the reporting obligations on that. In terms of, and the other thing too is if GPs who visit RACFs, if they get vaccinated, as we hope, then what we'd say is please, you're welcome to attend one of the GP respiratory clinics. Those GP respiratory clinics are based in Bondi Junction. One's based in Lakemba. One's based in Balmore, and the other one is actually at Olympic Park. And they are quite large practices who are involved in delivering vaccinations. And if you say you're a GP, you'll get some special treatment, I hope. But you're able to access as GPs the vaccinations being offered at those clinics. The other thing too I'd say is that 1B commenced on the 22nd of March. We had, I think, 46 practices who commenced in week 1 on the 22nd. We are progressively onboarding practices over the next 3 weeks. So we've had another 30 start this week. We expect another 90 to start next week. And in the 4th week, another 119. That essentially will bring us up to about 286 odd practices who will start to deliver vaccines under 1B. Respiratory clinics obviously had a very key and leading role in relation to COVID, but their role is continuing. but they're going to become, if you like, vaccination type clinics as well. So they'll be, they have the capacity to upscale, and so those clinics will be now working to really deliver the Astrazeneca vaccine. So I've mentioned to you where they are, but their role is increasingly going to move, as well as, of course, undertaking COVID testing, but increasingly what they'll do now is focus on delivering the vaccine. Perhaps the next slide, Brooke. Okay, thank you for that. So how you can support, so for those practices who are not under phase 1B, and you will remember that there was an expression of interest that was developed, and really the expression of interest made it such that only those practices who were accredited were able to apply for the EOI. But if you weren't accredited, but obviously you're still wishing to support your patients, then I guess the first thing to do is to try and identify those who are eligible through running them through your practice software in terms of applying the criteria. Then direct them to the COVID-19 vaccination eligibility checker, and they can find a vaccination clinic near them to make an appointment. Now, and of course also assist them too with proof of eligibility. If they're a healthcare worker, you may need to, may need to provide some proof, or you may need to assist them in that. And I mentioned before around where to vaccinate yourself and your staff, which is of course the GP respiratory clinics. Can I also indicate too that the issue about vaccine hesitancy was raised earlier, and can I just add something to that if I may, which is the Commonwealth have today released a package of communication materials that'll target people from called backgrounds and those who may have higher levels of vaccine hesitancy. We'll now be distributing that information. It's in multiple languages, out far and wide. So Brooke, that's now gone on our website. Perhaps you could distribute them to the people who are attending this event tonight, and you could put a link in and just let people know. And they're obviously, of course, able to be circulated. And I think the other thing, I'll just go back in a way. Thanks, Brooke. Once you identify those eligible practices, it's also about giving your patients the practical advice on where they can go to, as well as, of course, going to the vaccination eligibility checker. You might also know the practices near you who are also involved in that, and so you might be able to help facilitate that as well. Brooke, yeah, the next slide now. So who's going to be involved in what will phase 2A look like? Well, phase 2A will look quite different, I think. One, it's a different population group, and secondly, I think it'll involve quite a different application process than what happened under phase 1B. I think phase 1B, there are a lot of concerns, and we're dealing with a patient cohort that had more risks. In phase 2A, we start to move now towards more of the general population. So I think there'll be an opportunity for practices who are not accredited to be involved. There'll also be an opportunity for pharmacists also to be involved as well. So in other words, there'll be a much broader rollout and more opportunities for patients or for the community members to get vaccinated. So in terms of how practices can be involved, well, let me give you a really top tip. We're going to be sending you a lot of emails around how to get involved. So read your emails when they come from Central and Eastern Sydney PHN, and we'll give you, if you like, some of the top tips on how to be involved. And more broadly than that, there's other information that can be obtained not only on our website, but also the Australian Government's website. I think what you'll find is that there'll be plenty of notice given, and I think the participation requirements will be less than that of phase 1B. Now, the question that I'm asked most days is, when is phase 2A anticipated to commence? Well, I don't exactly know that, but if I were to make a judgment call on this, between these virtual walls, what I would say is, I think that once phase 1B gets settled down a bit more, then I think phase 2A will come fairly quickly. But it's partially dependent, though, firstly on vaccine supply of Astrazeneca and the capacity of CSL to rapidly upscale the production of the vaccines. We know that they are attempting to do that at the moment, which is fantastic, and they're producing vaccines, but they're obviously wanting to do that at a higher volume. So I think that will also be one of the rate limiting factors in terms of the supply of vaccine. I also think too that when phase 1B gets a bit more settled and people feel comfortable, then I think there'll be a need then to broaden it out to the community and for phase 2 to kick off. I don't want to put a timeline on that, but I think it'll be sooner than what people expect. There is a national priority to reach out to the community to really try and get the population vaccinated, which is why I think the time frame will be relatively short. And again, people in the community will have a choice to go to general practice or to go to pharmacies, or indeed there might be other service options that develop as well. And so obviously the Commonwealth are looking at the speed of the rollout and considering a range of options to try to increase that. And one only need to look to overseas, to perhaps in Israel and the UK, that provide some clues in terms of what other service options might be available. The next slide. So look, Brooke has very kindly put together the slide in the immunisation team, so thank you for that. So on the slide, we've got a lot of resources that we keep updated, and indeed our website is updated daily, so it's fresh and current. We also have an email address, which I suggest that you take it down, which is if you've got a question on coronavirus at CESPHN.com, but also if you need some dedicated support from a practice support team. Our practice support team are made up of some pretty skilled people, and there's probably not a question that they haven't heard at the moment. So email the practice support team at cesphln.com.au, and we've got a team of about 7 or 8 people now who are really supporting general practices to be onboarded and to start vaccinating. So again, and what we try to do is turn around those emails really quickly. Like we sort of jump on the email, respond, and we also produce some FAQs when we get some commonly asked questions. And can I also acknowledge to our really fantastic immunisation team, Brooke, Kara and Mimi, best in the business, quite frankly. And if you've got particular questions around cold chain management, etc., then they are the people that we turn to. And again, we've put their email address in there. And again, they're just as quick as the practice support team, no competition. But we'll get to your inquiry really soon. I think that's all, Brooke, and I'm happy to hand back to you, I think.
I've actually got some questions for you, Brendan, if you're interested.
Great.
So first one is on the COVID EOI applications for phase 1B. Yep. Is there any arrangement for GPs who did not register their interest as COVID vaccine providers initially? Can they become providers in 1B now?
Yes, so at the moment, the Commonwealth have locked it down for the moment. At the moment, there is not the capacity to do that because there are quite stringent requirements around that now. But let's wait and see after those practices who initially signed up, once they get onboarded, there might well be the capacity to open it after that. But I think the Commonwealth has made it fairly clear that they want to get this initial cohort of practices onboarded, and then let's see what happens. But for the moment, no. In the future, maybe. And let's see. But when that information does become available, we'll let you know.
Okay. Next one in regards to COVID vaccine consumables. So we've been allocated 400 doses of the COVID vaccine per week, so that's a big one. We haven't received any needles yet, though. We've followed up multiple times with the Linfox delivery, but no answer. We've already given almost 400 doses now. I hope we're going to get needles soon. Any advice?
So I'm more than happy to give you some advice on that. So firstly, if the questionnaire can email the practice support team, and I will intercept that email because that's an issue that I've been dealing with tonight. So there have been some issues around the supply of syringes and needles that we're aware of. What we are saying is that if there are undue delays in that, then my advice to you is think about your supply lines and your suppliers, and whether you can't also consider using those if there are going to be delays in ordering the syringes and needles. Now we have today, by the way, escalated that issue to the Commonwealth Department of Health to try and get a more immediate response on that. The PHN does not, we supply gowns or masks per surgical and N95 masks, but we're not supplying syringes or needles. That is the Commonwealth's responsibility. Having said that, we're hearing increasingly concerns from practices around the supply of needles and syringes. So this has been rapidly escalated today. And what we are encouraging those practices, though, to consider using your existing suppliers if there's going to be delays. All I'll say is watch this space, because we have escalated, and I'd really encourage that questionnaire to email us. And if you really wanted to, I'm happy for you to CC me because I'm really keen to hear this feedback. All right.
Okay. A question about the COVID vaccine allocation. Why have some GPs received 400 doses a week and mostly only 50?
Yeah, another fantastic question. I shall try and give you a very short answer on this. Well, the Commonwealth have developed a distribution formula. And originally we were going to have a relatively small number of practices delivering a large number of vaccines. However, that policy direction was changed. It changed in terms of having a larger number of practices delivering a smaller number of vaccines. And overall, that was the change. And so, and part of the issue there was around getting better geographical spread. Okay. Now, the other thing that's impacted this has been the supply of the vaccine, and I don't want to underestimate this. The supply of the vaccine has been a really significant issue that we think will be addressed going forward as CSL ramps up production. I would expect that those practices who are able to demonstrate that they can successfully administer 50 will get more vaccine supply. Okay. This is something that the PHN are going to be keeping an eye on in terms of how practices utilise the vaccines. So I would hope that the amount of vaccines that you're getting would be increased. And again, in terms of the why, I've sort of answered that, but in part it was around a Commonwealth formula that took into account equity and geographic distribution, and also the capacity of some of those early practices who put their hand up to deliver the vaccines.
Okay, I think there's one more question, Brendan. If you know, in regards to COVID vaccine access and equity, we have a problem with a local surgery that is a COVID vaccine immuniser telling our patients that they are prioritising their own patients, therefore refusing our patients. Is that okay?
It's not okay, but we also understand as to why they might do that. One of the requirements of participating as part of 1B was that practices who were administering the vaccine had to include or have the ability to be able to vaccinate those from other practices. Okay, and so that was one of the key requirements. Okay, but it's also somewhat understandable that those practices might, given the limited supply of vaccine, might want to focus on their more at-risk patient population groups within their practice. I would think, though, that as the vaccination supply increases and as the number of practices participating as part of 1B increases, that those issues might start to diminish. I would hope so.
Okay. And in regards to COVID vaccine record cards, for the COVID vaccination, are we going to receive immunisation cards to give to the patients after their Astrazeneca immunisation as a record, or do we just direct them to AIR for their records?
Well, I know we're getting some cards that's about to be sent to us. So we're getting those cards. In fact, I was involved in a discussion this morning via text. So we should have those cards in the next 24 hours. And then we'll distribute them to practices.
Okay, and the last one, our vaccines were delivered with a cold chain breach in transport. We therefore cannot use the vaccines. VOC have still not got back to us 5 days later. We've had to cancel 100 people,
okay.
and our next delivery, this might be a specific one that we respond to one-on-one.
So can you please email the practice support team and please CC me into it. But again, you know, our practice support team are legends. They're very quick to respond. And if you CC me in, it just brings it to my notice. We'll make sure that you get a personalised response, and we'll try and sort this out for you. Okay.
That was all the questions for you, Brendan. There's one there that I can quickly answer, which just in regards to the post-presentation review. It will pop up at the end of the webinar. If you happen to log off earlier for any reason, it will also be sent to you as an email in follow-up if you haven't completed it. Pass back to Margot.
Thank you so much, Brendan. That was really helpful. And I'd just like to add to some of those really great resources that you have up there. There's health pathways for all of our regions, have some very up-to-date information with some really good leading. The Hunter New England area have been leading that and doing a fantastic job also keeping that up to date. Now, my next job is to introduce Brooke, which does seem rather strange because Brooke has been brilliantly fielding all of the questions. So now I'm going to formally introduce Brooke. So Brooke Willoughby Thompson is you're a project officer in the immunisation team, and I think you're just going to catch us up to date with what your team is up to now. Thanks, Brooke.
Yes, hi everyone. So as Brendan had mentioned, we do have a team of 3. So we have Mimi Campbell, Kira Wright and myself, and we're busy behind the scenes. So Kira and Mimi have been collating all the questions for us in the background. And I drew the short straw to ask the questions live. What I'm going to quickly do though is just take you through our website so you know where to find the information if for some reason you can't get hold of us or it's the middle of the night and you're desperate to look up information then and there. I'll make it quick. We're close to the end of time. So you should be seeing our homepage of our website at the moment. And up in the top right-hand corner, just near the search function, is coronavirus. If you click on that, you will find everything you need relating to coronavirus that we can supply you. If there's something missing, call us and call us out on it, and we will make sure that it is on there as soon as possible. On this page, you will find information about what the current situation is happening. There's some information about where to order masks if you need more masks. There's a large section here on COVID testing clinics where you can send your patients, including respiratory clinics as well, for those who need the respiratory check in addition to a test, and lots of other information in addition on that page as well. The second option, which is nicely in bold for you, is the hot topic of the moment, which is obviously the COVID-19 vaccine. If you click through to that, you'll come to a specialised page, which again has absolutely everything you should need in regards to the vaccine rollout. There is some information there about the Pfizer vaccine as well, but for you guys, the most important bit would be the phase 1B. And there's a nice infographic there which talks about the different eligibility for the phase 1B. There's some more information about the COVID respiratory clinics, what their involvement is, what you can do with those in regards to getting the vaccine for your own staff if you're not currently a vaccinating clinic, and some additional information there as well. There's also up-to-date resources here, and our website guru, who is Mimi, she has conveniently listed them all date-wise, because what we're finding out is that there is so much information coming left, right and centre that you don't know what you've read already. So you can quickly check in here and go, oh, 29th of March, I certainly didn't read anything then. I'll have a look at that one. So you'll know that it's the latest information there as well. There's also copies of the onboarding pack and information on priority groups as well within there. So please do take some time to have a look so you know what's there for at the time you might need it. Starting at the top of that page, you've got the general information, which is all the general information that you would need in regards to this. Also about eligibility checkers and things like that to direct your patients towards, and for yourself to look up if you need to. That's a handy way to find out what practices are currently vaccinating. If you're trying to find somewhere to send your own staff, you can pop in that they're a healthcare worker and go through, and it will then list all the practices that are currently offering the COVID vaccine and how to go about booking at that specific practice. Shrink that back. And really important, the training and education that is required, and also all the additional things that are there if you have the time and want to do some additional training. The mandatory stuff is right at the top, first and foremost, of course, and then there's also information about other different modules that you can do, and you can also go through to the immunisation specific education page, which has a wealth of information on all the additional things you could do, and you can all of these would add up to CPD points too, so always useful there as well. Going to the home page of the immunisation page, this is where you'll see our lovely names and contact details and the email address. The best email is always to email our general immunisation one, and then we can triage it amongst our team. Some of us are part-time, so you'll get a bounce back message from us if we're not working, and it'll have information about what to do if it's urgent. Really important, our immunisation newsletter, it used to be bi-monthly. Because there is so much information coming out at the moment, we've made it weekly for you. So you can subscribe to that. It sits within the Sydney Health Weekly. So the Sydney Health Weekly is the standard email that CESPHN sends out once a week. And within that, you will see the Immunisation Weekly. But you can subscribe directly here if you happen to realise you are not receiving the weekly email. You can also see past ones if you've missed anything over within our news and alerts section as well. You'll have the weekly update information there, and you can see all the historical articles listed out for you conveniently to have a look at. And I'll probably got 1 more minute left, I think, before Margot rings my bell. The education page for our immunisation has, again, the mandatory COVID training, but also additional ones. There are the weekly Commonwealth webinar in regards to the COVID vaccine, a really useful one for you to join weekly, and lots of other information. And don't forget also the benchmark practice nurse course that we've got going. It's not just for practice nurses, though it is targeted there, and we're offering a scholarship at the moment to encourage all of our practice nurses to upskill, increase their knowledge, and also to go through to the endorsed nurse immuniser, or authorised nurse immuniser, they call it in New South Wales, to complete that qualification as well. So please contact us, have a look around our website if you are a practice nurse and wanting to find more information about that program. We also have obviously the COVID vaccine page we've already gone through. We've also got now specifically pages directed towards specific professions. So we've got the aged care, we have an influenza specific page, we have a nurse specific page, and also a pharmacist page. But most importantly, the one that has been there for you forever and will remain is the immunisation resources page. Everything you need in regards to your standard everyday immunisations, your NIPs and everything else is here, including very important information about cold chain management down the bottom and how to report cold chain breaches. And also the other really important one is your air and proto access information, and of course anaphylaxis. There's information about the anaphylaxis training as well that comes up under the education page. We did want to take a brief moment to explain the difference between when you would contact us versus the public health unit in regards to immunisation. Any clinical type of question, like my patient has XYZ, should I be giving this type of vaccine? That's quite clinical based. We are not clinical trained. So we would just point you towards where you could find those resources. If you need an answer straight away, you'd contact the public health unit for that kind of information. You can also go to NCIRS, which is on our useful contacts page as well. Cold chain breaches, if it's definitely a breach, you know it's a breach, straight to the public health unit following the procedures for that. If you wanted help to work out if it's a breach, you're welcome to give us a call first and we'll guide you and then direct you towards the public health unit to report. And I think that is my time.
Thank you so much, Brooke. And I'd really like to thank your whole team. So 3 people, some part-timers, have developed some incredibly comprehensive resources for us. So we really do appreciate how hard you've worked, particularly over the last year. So thank you very much. Also like to thank Nick Wood, who we have run out of time, unfortunately, Nick, but that was a really, really great. I learned things in that, and I really love the way we had time for the question time, but we do look like we've run out a little bit. I was going to ask you my crystal gazing one about how on earth are the borders ever going to come down, Nick, but it'll have to go into the questions that we might be able to answer and send around. So any unanswered questions, we'll get answers and will be sent around to anyone who's participated